very good afternoon. I am Dr. Pushpita Sharmin, Infertility and IVF Specialist in Fertility Care and Research Center from Bangladesh. Now I am going to present my today's topic, Diminished Ovarian Reserve Challenges to Meet. Diminished ovarian reserve is a decrease in the quality and quantity of oocytes. It is a irreversible condition. Women are of reproductive age with regular cycles, mostly ovulatory. Response to stimulation or fecundity is reduced compared to women of comparable age. Now, there is, Barsettle noted a significant upward trend in the prevalence of diminished ovarian reserves. The prevalence of DOR increased from 19 to 26% in the past few years, which is really a major challenge in reproductive medicine. Studying the trends in DOR assignment in the Society for Assisted Reproductive Technology evaluated that poor ovarian response is a prediction and reported that there is increased prevalence of DOR from 19 to 26% from 2004 to 2011. Now come to the causes of diminished ovarian reserve, why it is increasing or the prevalence is increasing so rapidly. The causes are idiopathic, after chemotherapy and radiotherapy, genetic disease and mutations like Turner's, galactosemia, fragile X, FMR mutation, FSH receptor and inhibin B mutations, autoimmune like polyglandular syndrome, lymphocytic uveitis, Addison's disease, Hashimoto's thyroiditis, mom, smoking, like that. Disease causing ovarian damage, that is endometriosis, pelvic tuberculosis, pelvic infection, etc. Ovarian surgeries, tubal surgery, uterine artery ligation, and endometrial toxins like endocrine disrupting chemicals, heavy metals, lead, mercury, cadmium, pesticides, bisphenol A, phthalate, cigarette smoke, certain chemicals used in plastic, cosmetic, and sanitary products affecting female fertility. There is various research showing that there is effects of environmental contaminants on fertility and reproductive health. Bisphenol A exposure might be associated with DOR and infertility. Meanwhile, endometrial polyp is increased in women with high phthalate exposure. Therefore, the risk of exposure to endocrine disruptor chemicals for reproduction should be a matter of concern in reproductive aged women. And strong evidence proved that exposure to environmental contaminants could interfere with adult female and male reproductive function. So there is another challenge to combat. The establishment of normal values for ovarian reserve test is a challenging factor in interpretation of the test. According to the Bologna criteria, ISHRE defined poor ovarian response as when at least two of the following three characteristics are present, that is advanced maternal age, more than 40 years, or any other risk factors for poor ovarian response, previous poor ovarian response less than 3 oocytes with conventional stimulation, and an abnormal ovarian reserve test, that is AMH less than 0.5 to 1.5 and AFC less than 5 to 7. Am I audible? Am I audible? Am I audible?
Yeah.
Okay. Okay, thank you. And 2 episodes of poor ovarian response after maximal stimulation are sufficient to define a patient as a poor responder in the absence of advanced maternal age or an abnormal ovarian reserve test. The most important reason for the poor ovarian response is diminished ovarian reserve. And recently, the Poseidon group proposed a new classification of ERT in patients with DOR or unexpected inappropriate ovarian response, and 4 subgroups have been proposed. That is group 1, 2, 3, and 4. 1 and 2, there is age less than 35 years, and 2 more than 35 years. Their AFC and AMH is good, but subgroup A, there is poor response, less than 4 oocytes, and subgroup 1B, there is 4 to 9 oocytes retrieved. And in group 3 and 4, AFC and AMH is poor, and group 3 age is less than 35, and group 4 more than 35 years, but there is suboptimal response. Now come to the point, that is ovarian reserve test. As woman reaches her mid-30s, the pace of oocyte depletion begins to increase, and by the time she reaches her late 30s, the number of follicles declines to approximately 25,000, concomitant with a significant increase in miscarriage rate. And after age 35, that decline speeds up. Nowadays, many women are delaying childbearing. 25% of women do not attempt pregnancy till 35 years of age. So there remains debate regarding ovarian reserve testing in the general population. Most of the times, diagnosis is often delayed as there is without any risk factor, and women with diminished ovarian reserve have regular cycles and are mostly ovulatory, also due to late marriage and delayed childbearing. Different biochemical and hormonal markers and ultrasound images help to estimate the number of oocytes in ovaries. Today, the marker most often used in clinical practice are the basal test FSH, antral follicle count, and anti-Mullerian hormone test. Basal FSH cutoff values have been reset from 25 international unit to 10 international unit to detect expected poor ovarian response and failure to conceive. And basal estradiol, early follicular estradiol levels are better used with basal FSH to assess ovarian reserve. And anti-Mullerian hormone, AMH declines years before a rise in FSH is seen, thus proves to be more sensitive biomarker of ovarian reserve. And as a general guideline, serum AMH values for the following 5-year age interval to be approximately 0.5 nanogram per ml for 45 years, 1 nanogram per ml for 40 years, 1.5 nanogram per ml for 35 years, 2.5 for 30 years, and 3 for 25 years. And antral follicle count is the sum of follicles in both ovaries as observed on ultrasound in the early follicular phase of the menstrual cycle. Antral follicles are defined as those measuring 2 to 10 millimeter largest mean diameter on 2-dimensional planes. And antral follicle count cutoff points of 3 to 4 follicles are highly specific for predicting poor ovarian responses, and there is high cycle cancellation rate. And the picture showing different follicular stages reflected by ovarian reserve test. And AMH shows in study research article that there is a high sensitivity and specificity to predicting the ovarian reserve. It is estimated that approximately 10% of the general female population will undergo accelerated loss of ovarian reserve, leading to loss of fertility from their mid-30s and early menopause by age 45 years. However, over the past 2 decades, the average age of a mother at her first birth has steadily increased and is currently 30 years of age in the Western world, with a further 1 in 5 not having commenced pregnancy attempt by 35 years. Now come to the point, the major challenge is management. As the fecundity is declining worldwide and ovaries are aging fast, nowadays more patients seek fertility treatment with decreased ovarian reserve at younger ages. Despite significant advancement in assisted reproductive technology, decreased ovarian reserve or poor ovarian response is still considered one of the major challenges in reproductive medicine. And the condition is frustrating for infertile couples due to low treatment-related conception rate, higher cycle cancellation rate, and high treatment expenditure. So in clinical practice, the measures most commonly used for these patients include an increased gonadotropin doses, the adoption of a short gonadotropin releasing hormone agonist protocol, that is the flare-up protocol, and reduction in GnRH agonist doses to reduce the excessive inhibition of ovarian function. Here comes high-dose gonadotropin. Studies shows that increasing the dose above 300 international unit does not benefit the patient in terms of live birth rate. And the addition of recombinant LH or recombinant FSH during ERT may have a beneficial effect on outcomes in women with poor ovarian response, as it leads to increased FSH receptor expression, follicular growth, improved follicular recruitment, and reduced rate of granulosa cell apoptosis. Agonist and antagonist protocol, different studies shows that With regard to whether the GnRH antagonist protocol is superior to the GnRH agonist protocol in poor response patient undergoing IVF, the use of GnRH antagonist protocol was recently recommended for poor response patients. And there is showing different systemic review and meta-analysis if the effectiveness of GnRH antagonist in poor ovarian responders. And it was found that the stimulation period and gonadotropin dose both are statistically significantly lower in the antagonist protocol compared to the long GnRH protocol. And the cycle cancellation and clinical pregnancy rates are not statistically significant different between the two groups. And letrozole and clomiphene-cited concomitant use with gonadotropin was lower, is comparatively, and gonadotropin used in letrozole groups was lower with comparable pregnancy and live birth rates between the groups. So we can use letrozole concomitant with gonadotropin. Here comes mild stimulation protocol. Mild ovarian stimulation approach in poor ovarian response offers some advantages such as patient friendliness, reduced duration and dose of gonadotropins, and overall cost per ovarian stimulation cycle. Recent meta-analysis found that co-treatment with clomiphene-citrate or letrozole, even though economical, had the lowest probability of resulting in pregnancy. And we can use dual stimulation. That is, besides follicular phase stimulation, we can do luteal phase stimulation for oocyte accumulation, and it is the better option for poor ovarian response and diminished ovarian reserve, though it is not cost effective for the patient. And dual trigger is another option. Here in poor ovarian response, by dual triggering, number of oocyte, metaphase 2 oocytes, fertilized oocytes, and day 3 embryos and top quality day 3 embryos were found in different studies. And we can use adjuvants like androgen dehydroepiandrosterone. Pre-treatment with dehydroepiandrosterone and or testosterone has been investigated in a few small trials with conflicting results. And antioxidants, coenzyme Q10 reduces mitochondrial oxidative stress, resulting in improved oocyte competence. And different studies show there is positive result with using coenzyme Q10. We have also done a retrospective study in our center, and in 140 patients, we give DHEA and coenzyme Q10 both, and the other group we give DHEA alone, and the study result was significantly lower amount of total gonadotropin doses was needed in coenzyme Q10 and DHEA group compared to the DHEA, and the number of mature follicle more than 18 millimeter and metaphase 2 oocyte retype was also higher in the coenzyme Q10 and DHEA group compared to DHEA group alone only. Here is the result that fertilization rate and cleavage rate was good, and good quality embryo were significantly higher in women treated with coenzyme Q10 and DHEA than DHEA only group. We can use growth hormone, though it is in our perspective, it is an expensive treatment, but it shows good results in some research. And we can also use melatonin, and we are using in our country in patients with DOR with melatonin pre-treatment. Newer approaches yet to be established, that is platelet-rich plasma therapy, stem cell therapy, in vitro activation, drug-free in vitro activation, mitochondrial transfer, and ovarian transplantation. ART like IVF is a costly and not easily available option in developing countries like Bangladesh, as all patients with a diminished ovarian reserve cannot afford to do IVF in our country. So in some patients we have to apply other treatment strategy like adjuvants, ovarian PRP, following by intrauterine insemination, and we are doing that. And there are some pregnancy reports with these treatment strategies. A prospective observational study was conducted at the Department of Reproductive Endocrinology and Infertility, BSMMO, Bangladesh from July 2019 to June 2022. And laparoscopic ovarian PRP was given to the patient with diminished ovarian reserve. And the result was there is significant raise in AMH level, AMH raised, and the pregnancy rate is 20%. Here show the result. And the other option is social egg freezing, though it is not done in some countries, but in the trending, increasing the rate of diminished ovarian reserve, it will be a promising option, can be a promising option. And the last option is oocyte donation to offer hope to the patient with diminished ovarian reserve. Though in our country, as a Muslim country, we are not doing oocyte donation. Despite significant advancement in assisted reproductive technology, diminished ovarian reserve or poor ovarian response is still considered one of the major challenges in reproductive medicine. New views and insights on the molecular and cellular regulation of follicular development and ovarian reserve are prioritized to provide more information for research on the treatment of DOR. As fertility specialists, we should make awareness among the general population about the age-related decline in reproductive potential, avoiding unnecessary surgeries and offering alternative therapies to reduce the burden of iatrogenic diminished ovarian reserve. Fertility preservation in cancer patients by cryopreservation of ovarian tissue, oocyte, sperm, or embryo before chemo radiotherapy. Awareness of a healthy environment and healthy lifestyle. Media is one of the excellent sources for spreading information, national and international policies to minimize environmental pollution. Thank you all. Thank you for giving me the opportunity to presenting my topic presentation.